Okay, it's almost 5 after 1. Institute for Public Policy and Social Research at Michigan State University. And I want to welcome you to the second half of today's virtual legislative staff training. This morning, we covered the Consensus Revenue Estimating Conference information and its impact on the Michigan State budget. And this afternoon, we'll be covering issues related to COVID-19, the novel coronavirus. A couple of let's see here, tips regarding our let's see, here we are, our Zoom webinar tips. So participants are indeed muted. If you'd like to ask questions, you can click on the Q&A button on the Zoom bar, or you can raise your hand if you like, and I will unmute you to ask the question. Some tips on being able to see everything. I'm sure many of you have been on these Zoom broadcasts over the last couple of months. And then our panelists will be sharing their screen, and a tip there on how to share the screen as well. So let's get started with our panelists. Today we have with us Dr. Deborah Holden, who's the Associate Dean for Public Health Integration and the Director of the Flint Center for Health Equity Solutions in the College of Human Medicine at Michigan State University. Dr. Jack Lipton, who is Chair and Professor of Translational Neuroscience in the College of Human Medicine at the Grand Rapids Research Center at Michigan State University. And finally, Gwyn Ann Sheely, who is an Extension Specialist with Michigan State University and will be talking about Extension's programmings and their efforts at ramping up their programs over the last couple of months. So with that, just a reminder that this session is being recorded and will be made available later. Let's get started with Dr. Lipton. Thank you, Dr. Lipton, for joining.
Thank you very much, and thanks for having me again. So today, I'm going to share my screen here, and today I'm going to talk to you about issues relating to COVID-19 testing. I'm going to give you a little overview of the interconnection between Health and Human Services and some of its other offices underneath it, talk about testing and how it works, go through how results are interpreted, talk about supply and demand for current viral testing, and just kind of give you all an up-to-date situation with respect to how we're testing, how well we're doing, and what we've learned so far. So let's go through it. So today the objectives are going to include understanding HHS and its interplay with the Centers for Medicare and Medicaid Services, the Food and Drug Administration, and the Center for Disease Control and Prevention. We're going to go through the steps and principles of viral testing. So we're going to talk about the difference between viral testing and antibody testing. We're going to talk a little bit about viral testing and what the difference is between being positive for the virus on the test versus being infectious, which is related to some new CDC data, which you should know. We'll go through the principles of antibody testing. We'll talk about supply chain challenges for each of these, and talk about some supply chain solutions which might alleviate some of these issues. So first, let's go through everyone's favorite. How does the government work? I think you all may know a little something about this, but let's talk about what everyone does under Health and Human Services in relation to COVID-19. So the Centers for Disease Control and Prevention are responsible for detecting and responding to new and emerging health threats like the coronavirus that we're all dealing with now. They developed the first Food and Drug Administration authorized test for SARS-CoV-2. That test was not trouble-free, and I can go through a little bit of the details of what the problem was with that and why some of these regulatory issues are very important. The Food and Drug Administration approves the products and processes for diagnostics and treatment of COVID-19. They run the EUA process. Is that a dog I hear? It runs the EUA process, which are emergency use authorizations. So in this case, when the Food and Drug Administration allows something to go into use, it's not necessarily an approval, it's an authorization. So we'll talk about that. It's an expedited application to the FDA that authorizes the use of a process or technology. It's not going through the full FDA process. And so it's used for emergencies, hence the E in EUA. The Centers for Medicare and Medicaid Services, they set the reimbursement rates for COVID-19 testing for Medicare and Medicaid, and that's kind of the gold standard for the pricing. The pricing has changed over time. Originally, the Centers for Medicare and Medicaid Services were paying $52 a sample. They are now paying $100 per sample, which has really affected the market and priorities. And I think it has, while it's great to have good reimbursement like that, it has produced some challenges based upon differential pricing for insurers versus Medicare and Medicaid. CMS also interprets and manages the standards for accrediting laboratories. And so for those of you who don't know about CLIA, this is something that we in the laboratory world know about. The Clinical Laboratory Improvement Amendments were passed in 1988, and they pretty much determined the regulations whereby clinical laboratories that offer diagnostic services, how they function, what the basic rules are, and those are set by CMS. So all three of these institutions have this interplay with respect to what their jobs are. And CLIA labs, interestingly, are not the only ones. They are not only the ones who can test for coronavirus, but they're the only ones who are allowed to develop tests. So this is another problem with the system, which we have come across because of what we're doing. And I'll get into that a little bit later. So how does viral testing work? So you've all heard, everyone's like, more tests, more tests. What's going on with this test? And so the viral test is a direct test for the virus. Okay, this is different than the antibody test, which we'll go through after this. In order to have a positive on this test, you have to have active virus in the body. The way it works, this is the process that we go through. We collect a sample, and it can be done either through a nasopharyngeal swab, which is somewhat uncomfortable. A nasal swab, we've actually been piloting new ways to do sampling. And so we've used a nasal swab, and we were using these because of the supply chain challenges that you've all heard about. So getting enough of these nasopharyngeal swabs, most of which were produced in northern Italy, which was hard hit early in the pandemic, of all places on earth to be hit. So we've had to switch and try different things. We've used nasal swabs, which don't go as far into your nose. And then we've also developed a saliva kit. And so a couple of other manufacturers have been working on this as well. We've developed our own home-built saliva kit that works pretty well. So you collect a sample through the nose, or you spit into a tube right here, shake it with a preservative in here for 5 seconds. We actually really like the saliva setup because you don't have to keep the sample on ice like you do for a nasopharyngeal swab. There's a preservative in here that inactivates the virus and preserves the genetic material, and you can leave it at room temperature for a couple of weeks. So after we get that sample into the laboratory, we extract the viral genetic material. And so we all know that our genetic code is DNA. Viruses like this are different. They have an RNA genetic code. And so we take that genetic material, we extract it from the sample, and then we have to turn it back into DNA. So we have a process which we call transcription, where we take the RNA as starting material, and then we create DNA from it. After that, we take it and put it into a machine to amplify the signal that it produces and detect it using a dye, which produces a fluorescent signal. And it runs in these cycles. So there's a heating and cooling cycle every time we do this. And we run through about 40 cycles of this heating and cooling process, which allows us to each time double the amount of genetic material that shows up inside of that tube that we are examining. And if there's a sample in there that's positive, we'll start to see, as you can see, this green line is flatlined, but then it starts to go up, and when we have a signal that's positive, we'll start to see the growth in this fluorescent signal over time, and then it plateaus. If it's not there, we will just have a flat line all the way across. And so that's how we can tell the difference between a positive test and a negative test. The dangers that we have in terms of what these tests have in terms of shortcomings are mainly false negatives, and these are related to the sensitivity of the test. So this is what we call a polymerase chain reaction test. This is a complex molecular test. And part of the problem we have with this is that we only run the cycle out for about 40 cycles. And so after that, you can get spurious growth in this curve for material that's not specific to the virus. And so we don't run it past 40. And so because of that, if you don't have this line coming up by 40, and you don't have that much virus in the body, this test may not get into the linear phase during the amplification process. And if that happens, it looks like it's negative when someone is actually still positive. And some people have a lot of virus in them. Some people have very little. And when they have a lot of virus, it's very easy to detect with this. But when there's a little, you can miss it. And so we've developed a new test. It's called a droplet digital PCR test. It uses a different technology. And that test is about 500 times more sensitive than the standard PCR test. And when you, there was a study that came out of Wuhan, China, which we based our study on, or our process on, and they found that in people that had recovered from the coronavirus, they had 14 subjects that had recovered and had tested negative using the standard test. Of those 14, when they were tested with droplet digital PCR, 9 were still showing presence of the virus. So that's a little bit concerning when you have a test that isn't that sensitive. You don't really have false positives with this kind of test because this test is a genetic test, and the genetic sequence of the virus has to match the materials that we have, the reagents that we use in the test. And so it's very, very specific. If you don't have it, you're not going to show it. The ways that you can get a false positive is if someone is cross-contaminating one sample from another, right? So if you have a lousy technical staff member in a lab and they're pipetting stuff and they touch the tip from a positive sample to a negative sample, you can contaminate the sample and get a positive. But other than that, the test will not show you a spurious positive example. So now let's talk about that issue relating to viral load and whether you're showing positive on the test versus whether you're actually infectious. So the CDC offered up an advisory on May 3rd, and they wrote, for persons recovered from COVID-19 illness, the CDC recommends isolation to be maintained for at least 10 days after illness onset and at least 3 days after recovery. Illness onset is defined as the date symptoms begin. So we have a study that we are running right now. So we run a non-CLIA certified laboratory. We are strictly university research. So we have a test running. It's superior to the standard tests that are being run. We can't offer this up as a clinical test, but we can use it for research purposes. And we are currently using it to understand spread among MSU faculty and staff and also spread in the community. We're not using it as a diagnostic test. We're using it for more of a public health indicator of what's going on. We had one particular subject early on in our study who was positive for 6 weeks. And so you see this whole issue about 10 days after illness. We were very worried when this came out in May 3rd, and we had tested this person back in April because they were positive for 6 weeks, but the CDC is saying you're only infectious for 10 days. So let's look at that data. So you can have people that test positive for the virus for up to 6 weeks. But after 10 days, there was a study that was done very recently which showed that that the virus that people have in their bodies once they get past about 10 days can't be grown in a laboratory. So if you see here, whether you can successfully culture or grow this virus when you get it from someone's body in the lab, there's a 1 here for no, a 2 here for yes. And these are the days post-symptom onset. And you can see here, each one of these points with its own special unique shape is a person and their test of whether they could take that and grow it in the lab. And it's only those within 10 days of symptom onset that you can grow in the lab. Everyone past 10 days means that virus, while it's present in the blood, it is not replication competent, which means that there is viral material there that we are picking up in our test. The genetic code is there. The virus may still be expressed by the person, but that actual virus is probably bound up in an immune response, and it's been damaged sufficiently so that it can't infect someone outside of your body. So your body's still shooting some of them out, but it's not going to make someone get infected. And here's another example showing the, I'm sorry, some of these words are really tiny, but this is the overall survival of the virus here and days after symptom onset. And you can see that the ability for someone to grow that virus pretty much ends before day 10. And so they feel pretty safe to say 10 days after symptom onset, people are no longer infectious. I think it's a pretty bold statement to make based on what I'm seeing on the test, but based upon the laboratory data, I think it's a pretty solid assumption. So let's go on to antibody testing. You're hearing a lot about this one, particularly as it relates to going back to work. So the antibody test is an indirect test. We're not actually detecting the antibody. We're detecting the antibody's interaction with an antigen on a test strip. And so this looks at your immune response after viral exposure. And so how do these work? We collect a sample of blood. We usually do this with a lancet, which is a finger stick. People can also give a blood sample, but it's much easier, and you don't need very much blood for this to just do a finger stick like you would do for diabetic blood testing for blood sugar. You mix it with a buffer in a test tube or an Eppendorf tube, and then you take that sample and you place it onto a cartridge. This is what these cartridges look like. You've probably seen them on the news. They're about 2.5, 3 inches long. And then each cartridge, you can see right here, has a port. The B is for blood. And then the main points you have to worry about here are the IgM, the IgG, and the C. So when you put some blood on here that's mixed in with that buffer, that sample spreads out across the paper that's in here. It's kind of like a paper material, and it spreads across here. And then there's an invisible strip of material here. There's an invisible strip of material here, and there's an invisible strip of material here. When that buffer and blood runs across here, if this C line shows up, that means that you did the test right. This is the control line. And so you know that the test is working if you get that line. The IgM line is an immunoglobulin type M, which is the short-term immune memory of your body. So when you first get an infection, the first thing that shows up in your body in terms of its response as part of the adaptive immune system is IgM. And then after that, you'll produce IgG. So IgM will appear 2 or 3 days after you get exposed to a virus. IgG will usually take a couple of weeks, but it's different depending on the person and how robust your reaction is to the virus itself. And so if you get an IgM line without an IgG, that means you're early in the infection process in your immune response. You should typically get and then if you have an IgG line without an IgM, that means you probably were exposed a long time ago and your IgM response is gone. If you get both, that means you're probably in the recovery phase and you're showing a strong immune reaction. And the danger with these tests right now are both false positives and false negatives. I'll give you an example here. Also here, this is just giving you an idea of how long these things take to appear. This is the IgM response in green. So what percentage of people after days of symptom onset start to show an IgM response. And so you can see for you to get to pretty much a full immune response, you're talking about 3 weeks after exposure. But let's take a look at this false positive and false negative issue. So this is a test. We got this actually from a manufacturer who was importing them from China. And this is someone in West Michigan. And we ran this on that very same subject that I told you about that tested positive for 6 weeks. So this was after 6 weeks. And you can see here the control line shows up for this particular subject, but there is no IgG and IgM line. So either this patient doesn't have, even though he's recovered, has no immunoglobulin response as his immune response, which would make no sense because he's recovered, or the test is crap. So I'm going to go with the test was crap. And this is part of the problem, is that the FDA was allowing tests like this to go onto the market without even an EUA. So there were dozens of companies that were putting these things out, and they weren't tested at all. And so when these things flood the market, there's either a false sense of security here, either people think they never had it, or there's also quite often a cross reaction. So there are other kinds of coronaviruses out there. There are 4 coronaviruses that humans have been exposed, that humans carry, and they're kind of like cold viruses. So if you had a cold a few months ago that was a coronavirus, and you had an immune response to that, it may show up as an IgG or IgM line on here. And it's important to have the appropriate antigen on these tests, the thing that reacts on this cartridge. If it's too general to several different coronaviruses, it's not going to tell you that you're safe. You're going to think that you're safe from COVID-19 because you're like, oh, I got sick 2 months ago and I'm fine. And then you're going to go and get it. And so we don't want people to either have a false sense of security from a false positive in this case, or these false negatives for people who clearly had the disease and were not showing a reaction. Let's talk a little bit about the supply and demand challenges. So you've heard a lot about the testing, you've heard a lot about antibody tests. Where are the supply chain challenges that we have currently with these tests? So for the viral tests, there are currently 48 authorized commercial tests as of last week, is the last time I put this slide together. There are two different types of tests that go on. So the authorized commercial test can be sold, and laboratories, CLIA laboratories across the country can use them. There are 25 lab-developed tests. So the FDA can approve a test that's very specific to only one lab. And so you can see I have listed there 10 universities. So Rutgers has its own test as an example. MIT has its own test. And they are approved to only be used at that location. So there's 25 lab-developed ones, 48 commercial ones. The supplies for these tests, depending on what you're looking for, the supply chain is still stressed. So collection tools, they're getting a little bit better, but it's still hard to get the nasopharyngeal swabs. There are saliva kits that are coming out, but even those, they're ramping up production, so they're not as easy to get. And a lot of labs aren't prepared to utilize the saliva versus a nasopharyngeal swab because the process of extracting the genetic material is different. And so laboratories have to get used to a new and operationalize a new collection tool. So that's a challenge. Extraction reagents, which are the materials that we use to take the sample and pull it off of our collection tool, whether it's out of saliva or off of a swab, so that we can just get that purified genetic material out. Those are also in tight supply. So typically those have been back ordered 2 to 3 weeks, and sometimes you'll get partial orders on those. Transcription reagents that taking the RNA and moving it to cDNA, very common material that's used in labs across the country, still easy to get. The detection reagents, which are also very commonly used in the PCR assay, and then having the primers that are developed that are designed specifically for the virus, those are easy to order too. You don't use very much of them, and they're pretty plentiful. Plates, tips, and other supplies. So we use our pipette tips to move samples around. We have these plates that all the samples sit in, and some of these plates are very specific to high throughput machinery. And so there are common versions of these plates, but you have to have the ones that fit exactly into your machine. And if that particular one is in high demand because it's being used for high throughput testing like this, some of those things could be periodically unavailable or back ordered. So that makes it difficult. Even though we have all the chemicals to do it, if we can't put it into a robot to run the machine, we still have a problem. With respect to the antibody tests, so if you remember, I mentioned something about the unapproved platforms without EUAs for those COVID-19 antibody tests. That was due to a decision that was made March 15th. They're like, just let everybody put one out. It's going to be great. These are all coming out of China. They're fantastic. They were not so fantastic. May 4th, the FDA backtracked on that and is now requiring emergency use authorizations because of these unproven, and some of them are just fraudulent. People are just selling stuff, and desperate points of care and individuals who are buying them outside of the market, outside of the health market, are running these tests on their own, and they're just fake. So it was a bad idea. The problem is that those are going to be around for a while. They're probably still going to be selling them, even though they are forbidden to be sold by the FDA. I'm sure you can still pick them up on eBay. May 7th, the FDA authorized 12 specific antibody tests. But the problem with authorizing all of those 12 tests doesn't mean they're available. A lot of these are still in the production phase, and so it's not that easy to get all of the different antibody tests that have been approved. So there is still a shortage on those. So we have two issues, right? We keep hearing all the time about not having enough testing, and that is true. But then, of course, we also have too many tests, which is also true. And so mid-April, I wrote an op-ed with my colleague, Carol Sortwell, talking about the need for laboratories like ours, university research labs that have the ability to run these kinds of PCR tests, to be enlisted in the process of testing nationally. The problem is that because we are a research laboratory and we are not a CLIA laboratory, we are not allowed to run those tests. We are not allowed to offer diagnostics, and we can't get reimbursed for those tests from CMS or from any other insurer because we are not authorized, which is part of the problem, right? We have companies out there like LabCorp and Quest who are collecting $100 a sample for this test. They are accepting those samples. They are they're putting those samples in a queue that allow them to hold on to it because they know they're going to get that $100. When there's other places where these tests could be run. But because of the regulatory framework that we exist in right now, we can't. And so we wrote this to say that we should be developing a pandemic national guard where we take laboratories like these, make sure they are ready for a crisis in order to be able to offer these kinds of high complexity molecular tests, and call them into action so that if needed, they can offer up these tests. You may only activate, you may have a cholera outbreak after an earthquake in Puerto Rico. You can authorize university labs just in Puerto Rico. You don't have to do it nationally. There's a lot of opportunity to develop a process for rapid response using academia. And I think that that's really what I've been trying to push. So this is a problem of not having enough tests. But there was also an op-ed that came out in The Hill that says the FDA has said yes too many times. And so this is related to those antibody tests, right? So at a certain point, we're too restrictive, and then at other points, we are too permissive. And so in the process for both of those, people don't get tested. We don't get the information we need. We don't get the contact tracing. We don't have a comprehensive testing schedule so people can get back to work. And that's a real problem. But that's where we stand right now. So what have we been doing to try and fix that? So we've developed some innovative solutions at MSU because of these supply chain issues. We've developed our own saliva kit. So you can see over here, this is a $25 kit that comes from a fancy company. And this is a $3 kit that we've developed, which basically is 2 test tubes, one with a little RNA preservative in it, transfer pipette, you spit into the big one, you move your spit up to this line, into this little one, you shake it up for 10 seconds, and you hand it in. This costs $3. And we've been utilizing this in 2 different human studies that we have approved, and it works just as good as the regular spit kit. And also, this is not a supply chain issue because we can make them in the lab. This just shows you what that looks like. So this is actually from that spit kit. This was the very first sample that we got that was positive from a spit kit. If you look here, these light blue speckles, this is for our droplet digital molecular test. Each one of the droplets here contains 1 copy of the virus, and we amplify that, and that's why it is in this light blue area. That's been detected by the machine. The other droplets, which are parts of the spit, the little droplets that we make in the process that don't have any genetic material in them. So if you had no virus in your body, you would just have a bunch of blue speckles like this, the dark blue ones. The light blue ones have the virus present. So you can see this is a curve showing you all the negatives and all the positives. So this is a positive sample. And this green material, you don't have to worry about so much. This is showing that it's a valid human sample that shows some of the human DNA that's in the sample. So that's pretty much how it works. We've developed a test. We've worked on saliva. We are trying to enter the national conversation to talk about these issues, to try and get changes affected. I talked to both Fox and MSNBC. I'm trying to talk to both sides of the aisle and to talk about the importance of this kind of work. If anyone has any questions about any of the work that we've done, there's my email, there's my phone number, there's my assistant's email. Please email her first. Thanks very much.
And thank you, Dr. Lipton. Greatly appreciate your expertise and perspective on testing. Very important, I think, for our audience to understand what's all involved in that process.
Absolutely. Let me unshare here. There we go.
Okay. Next up is Dr. Deborah Holden. Dr. Holden, are you available and with us right now?
I am available. I am with you.
Fantastic.
All right. Okay, great. So you already said who I am. I'm going to sort of jump right in and talk a little bit and give a little bit of the background and lay a foundation for a conversation about health disparities and health equity, especially as it relates to COVID-19. And just to get us all in the conversation, and thank you, Dr. Lipton, for sort of laying the foundation with what's happening in testing. I'll touch a little bit on testing, but just so that we're all in the same conversation. Health disparities roughly have been defined, and I'm using the definition that comes from Healthy People 2020 as a particular type of health difference that's closely linked with social, economic, and/or environmental disadvantage. I give another definition that was created by a very good friend and colleague, Dr. Kamara Jones. And the reason I give this definition is because as we move forward in trying to understand and advance health equity and eliminate health disparities, I think her framing of that is a little more nuanced, but really gets more at the heart of the matter. And she defines health disparities as the differences in outcome, but adds that when health disparities are eliminated, health equity will be achieved. And the reason I think that's an important distinction, if we again go back to sort of these leading guidance documents around health equity and health disparities, Healthy People 2020 defined health equity as the attainment of the highest level of health for all people. And again, Dr. Jones said it's not just the attainment, but it's the assurance of conditions for optimal health for all people. One almost treats health equity as a destination. One actually is more of a call to action, the way Dr. Jones defined it, as the assurance of the condition of optimal health for all people. And we'll talk a little bit about why that nuance is important in a bit. So last thing I want to sort of give as a foundational aspect of the conversation is the social determinants of health. And we've heard a lot about the social determinants of health. Dr. Daniel Dawes, who was employed in the White House and did a lot of work around the Affordable Care Act, has a new book coming out, and he calls them the social and political determinants of health. But again, our leading guidance, sort of Healthy People 2020, defines the social determinants of health as the conditions and the environments in which people are born, live, work, play, worship, and age that affect a wide range of functioning and quality of life outcomes and risks. You know, sort of underneath of that also, when we talk about the conditions, they aren't just the social conditions, if you will, but the social conditions, the economic conditions, and the physical conditions in the various environments and settings. And when we talk about settings or place, we're talking about things like where people go to school, where they go to church and worship, the workplace, neighborhoods, et cetera, is broadly how we talk about place. And then in addition to the more material attributes of place are the patterns of social engagement or disengagement and the sense of security and well-being. We know that those things are also affected by where people live and work and play and worship and go to school. So just to set the stage with framework, I like to give this example to people as a different way of sort of thinking about these things. And I always give the caveat, I don't place a value judgment on any of these things. And I'm not saying that one is better than the other. Again, I just think it's important for people to have some framing and some understanding about what we're talking about and some things that you can think back on and go back to when you're in conversations trying to distinguish some of these things. So this is an example of equality. And we've all sort of seen that. So here you've got three people of different heights, all at the baseball game. There's this fence up. And so in an equality model, everybody gets a box of equal size. And as you can see, the taller guy could see the game. You know, he's taller than the fence without the box. The guy in the middle was right at the height of the fence. He couldn't see. And so the box actually gave him access to be able to see the game. And the smaller person, even with the box in an equality model, is still not able to see the game. And you can think of the game as all the things that people, you know, would have availed to them for optimal health. In an equity model, it's more based on people having access to what they need. And so you can see the taller guy who already can see over the fence gets no box. The guy in the middle just needs one box and he can see. And the guy on the end gets two boxes, and now that has him be able to see and experience the game in a similar fashion as the other two. It's a really interesting thing because originally when I started doing this, I would focus on these sort of two boxes. And this is really important if you think about how we allocate resources, because oftentimes what we've had happen is an equality model. There's some carve out or set aside, and it sort of gets distributed independent of need. The equity model really points to let's distribute resources relative to need. And then the social determinants of health framework is more about the sort of removal, if you will, of the systematic structures and barriers that people have to being able to experience optimal health. And the reason I think this model is important to sort of think about, and again, no value judgment, you can just see that access and being able to see the game varies as a function of what framework and what model we're employing. When I put this equity slide up in Flint, a lot of my stakeholders pushed back and said, some sort of shook their head and said, yeah, that makes good sense. That seems great. And others were really offended by it. They wanted to know how the little guy got up there. Did the taller guy have to pick him up? Fundamentally, people should be able to maintain their dignity in the process of health and attainment and sustainment and assurance of health for all people. So even the equity model, we're all sort of easily seduced into thinking that's fair. But there are some people who say, what would it take to live in a society and in a world where people actually had access independent of what resources were being doled out to them? So that social determinants of framework model, it's not better than any of the other models or ways of thinking about it, but really depending on the community and the population that's being served, I think people should have a say in what's available to them. So the way I'd like for us to think about disparities versus inequity is think about disparities as the differences that we see. Think of them as very person-centered and downstream. And I'm going to talk a little bit about downstream versus upstream. And then inequities, I'd like for you all to think about inequities as unfairness and the systems and structures that typically are at play that give rise to the disparities that we see downstream. Oftentimes how we try to address inequities typically tend to be intervention centered, and those interventions tend to typically happen at a level that's larger than the person, and they typically tend to be more upstream. So this upstream, downstream language really comes out of the world of geology, and we've heard it a lot. I want to just a little bit of clarification, and I'm sort of setting the stage for a conversation that we're going to have about COVID. But upstream is defined and comes out of the term upriver. I just got a notice that my internet connection is unstable. Can you still hear me?
Yes, you're fine.
Okay, just making sure. If you can't, just like hop in and say, hey, Deborah, we're breaking up. I do have my phone available as a backup.
Okay.
Okay, great. So the term upstream typically refers to the direction towards the source of the river, i.e. against the direction of the flow. And you can sort of see here on the graphic, this is the sort of upstream part of the river. And downstream or downriver typically describes the direction towards the mouth of the river in which the current flows. If you put that in a sort of health framework, and I want to give just a few examples from the field, and you think about it in health, upstream thinking, and I have the source for some of these slides, which are not mine, but I thought, why create something new? There are already good examples of this that exist. Upstream, you can see a person sort of going in, and what happens is as they flow down the river, we try to implement things, and there's a person sort of pulling somebody out with a life raft, and then you can think of those as sort of hospitals and systems of care and how we deal with people once they're already sick. And then even further downstream, you can see an ambulance, and these are sort of like, tertiary care and other things. The thinking in the upstream world is what will it take to stop people from going in the river upstream so we don't need as much and don't add as much burden and work to the system downstream. And this was a great example that I found from the National Collaborating Center for Determinants of Health. It's a Canadian-based center. And they talk about and think of some of their upstream kinds of factors as things like, being socially inclusive and partnerships for affordable housing, and some of the more downstream things. And not that any of these things are bad or better than the other, but, where you implement sort of impacts how many people are making it into the river and having to then be impacted downstream. So things like treatment and housing are things that we would see more downstream versus upstream, things like being more socially inclusive and having partnerships for affordable housing. And so if you think and go back to upstream, the source of the river and the disparities, the real question is, what are the factors that we are dealing with, I think, as a nation, that we could better deal with upstream? What are those kinds of factors? If you all were unmuted, we could interact a little bit around it, but I'll leave some time at the end for some Q&A around this. And then again, what are the factors downstream at the mouth of the river, or where the disparities are actually starting to show up? So I'll just end this sort of overview part with talking about some of the gaps that we have in the field. Is that really what you see mostly in the literature and hear a lot from our leaders, and a lot of the initiatives that are focused on health equity, is we typically focus on what health equity is. Again, go back to that Healthy People 2020 definition, this attainment of opportunities for optimal health for all people. But mostly where we intervene is downstream. And the downstream interventions tend to be very costly and not scalable or replicable. We often don't focus on how we got here. How is it that we got to be such an inequitable society, both at large and specifically when you talk about health equity relative to health? And we also, again, don't talk a lot about how we achieve health equity. We describe it as a state or something that we attain versus the process and the work of how we assure that. And we almost never really deal with the causes of inequity and health equity in health and in our society at large. And I just note, dare I start naming some of the isms that are really at the causes of the causes. So as we move into more specifics about COVID-19, this issue around herd immunity has come up. So I did think it important to touch on it a little bit. And here in this visual, you can see that the folks in blue are the people who are not immunized but still healthy. The folks in yellow are the folks that are immunized and healthy. And the folks in red are not immunized, sick and or contagious. And what herd immunity is sort of basically defined is it's the indirect protection that you get from infectious disease that occurs when a large percent of the population has become immune to infection. And that immunity can occur through vaccination, it can occur through previous infection, but it provides some measure of protection for individuals who are not immune. And I ask you to sort of keep this image in mind, because people keep talking about herd immunity, and you can see sort of at the bottom where you've got the majority of people are immune to the disease, again, vis-a-vis vaccination or natural immunity that's come through infection. The likelihood of them coming in contact with somebody who is either not immunized or not protected, and even worse, somebody who's sick and contagious, the likelihood of people coming in contact with each other that fit those criteria are very low. When we get to that state, we consider that to be the herd effect, or that the herd, in this case humans, because this model also applies in an animal model, are typically protected. Our intended outcome with herd immunity is control or elimination or eradication of mostly vaccine preventable infectious diseases, but globally of infectious diseases. Some considerations for herd immunity or the herd effect in the US as it relates to COVID-19, a lot of people are talking about the Swedish model of herd immunity. And I just want to offer that that's not working as well as is being reported, and also as is not being reported. Specifically, they have a much higher case and death rate in Sweden than they do in the neighboring countries. There are multiple reports of avoidable deaths, especially in nursing homes in Sweden, and people really are not talking about that. And building herd immunity through natural immunity or infection will likely result in a lot of avoidable death and disability. So I just caution people against saying, well, it's working in Sweden, why can't we do that here? In the absence of a vaccine, we're literally playing Russian roulette with people's lives and accepting that, in essence, we are okay with a lot of premature and unnecessary both death and disability. And I think that's the risk we run with premature reopening especially in the absence of good public health practice and some of the things that Dr. Lipton has talked about, like good testing. And just another caveat, for us to really get there, not just vaccine development, but the vaccine development and then testing will actually take some time. And so I haven't gone over my time, right? I have until 2, right?
You're fine. Yep.
Okay, great. So some of the disparities that are facing us during COVID, I'm going to just do a quick snapshot of some things. And these data are basically still hold true, but these are early from COVID. What we saw is that early we saw a big hit and a big disproportionality of African Americans being affected. And this is just a quick example. And I am going to say a little bit about data in a second, where basically what we're seeing is that African Americans in many places are 2 to 3 times overrepresented in COVID-19 cases and deaths than they are in the population of many states. These are just a couple of our early headlines. When COVID hit St. Louis, their first early wave of cases, the first 13 or 14 cases, and the first 13 or 14 deaths were actually all African Americans. And since COVID does not see race, of course, these numbers have shifted. But the reason that I bring this up is because I think, what other sort of demographic groups could we have those kinds of early numbers and not really be up in arms? One of the things that I was really sort of as a public health person and somebody who's been monitoring health disparities way before COVID and working to help sort of achieve health equity, is that Massachusetts actually was one of the first states that came out and started to point to some of the why we're seeing these disparities. And I'll say a little bit more about that in a second. And they came out and said that they think that their policies and guidelines for how they prioritize ventilators and bed rationing, they actually think was prioritizing white patients over patients of color. And they actually started to deal with that and have narrowing the disparities as a result of that. So what we know is that we've got these confirmed racial disparities in cases and deaths in multiple cities and multiple states across the country. And a lack of data only continues to fuel that debate. In this slide here that comes from the COVID tracking project shows that a big problem that we have is that a lot of states don't even collect the data on race for not only, I'm showing specifically as an example, the death data, but many states don't even collect the data, let alone share it on who's getting tested, on cases, and on deaths. So I actually think that, yeah, we have these confirmed racial disparities in cases and in deaths in Michigan, but at least we've shared the data and the facts. And I want to note that from everything I've been able to identify, Michigan was in the first 3 states who were transparent and forthcoming about that. Now we're starting to see global studies and other populations racial disparities are emerging, and now states are being forced to share some of this data. And we've seen major emerging racial disparities in Texas as just an example, and many other places. And likely you can imagine, again, if the data were being collected and shared transparently, we predictably have these disparities showing up in other cities and in other population subgroups. So why? Well, what we've mostly pointed to are the usual suspects. We've talked a lot about pre-existing health conditions, increased exposure. Oh, there's medical mistrust, so people aren't getting care. Oh, there's more misinformation and misunderstanding. And then people have pointed a little bit to the social determinants of health. Mostly when people have been pointing to the social determinants of health, they've talked about things that are not actionable during the pandemic. They've talked about things like living in poverty. And not that those things are not impacting some of the disparities that we're seeing, but I feel like it's not the right things for us to be looking at if we're going to look at the social determinants of health, because there's very little that we can do right now to impact the social determinants of health, particularly things like poverty. And so I think we've accepted these usual suspects and explanations, and these explanations, and many of them are far from actionable. But the problem is that these explanations have actually been used to generate these algorithms and these guidelines for who gets what. And again, I applaud Massachusetts for being forthcoming about that, for acknowledging that, for looking at the data and saying the way we've, created these guidelines, we've actually prioritized some patients over others. We know that it's impacted who's getting screening, who's able to get mobile testing. I always tell people mobile testing is great, but most of the mobile testing sites require you to be able to drive to them or drive through them. If you can get to a mobile testing site, even in the face of, the gaps that we've seen in public transportation, you can't walk through the site. The same way you can't walk through a fast food restaurant drive-through, you're not able to walk through the drive-through testing. We know that some of these guidelines have also influenced things like hospital admissions and things like do not resuscitate orders, which are at an all-time high right now, because oftentimes patients are not able to advocate or speak for themselves, and families are not allowed in the hospitals. And I believe that these algorithms are attributable to a lot of the excess morbidity and mortality. And when I say excess morbidity and mortality, I'm talking about some of these tremendous disparities that we've seen. And I think they're literally killing people. So what are some of the solutions? I think we can reorder the algorithm. So instead of using these things to create guidelines that give people lower priority, we can turn risk into priority for a continuum of care. So if you have some of these social determinants of health present, they could prioritize you in the continuum of care. If you have pre-existing health conditions, that should prioritize you for hospital admissions and for some of these bed rationing protocols that we've seen the papers and we've seen the stories about people dying on gurneys in the hallway while others are in hospital rooms and things like that. Some of the major takeaways that I want to leave you with is I think we have to stop describing the problem and start implementing solutions. We need to map those solutions onto priorities versus using them as explanations for variation in care based on risk. We should focus on the factors that we can control and impact and stop blaming the disparate. There was a really amazing article that just came out. It's an international study, and it basically said that the disparities that we're seeing and the three major groups that have emerged so far are Asians, African Americans, and men. I think we need to focus on the factors that we can control and impact and stop blaming the disparate. I hope that all of you have got a little bit better steeping in both the distinctions between health disparity and health equity, and we can start to bring that lens to these conversations and start to look upstream at how we stop people from going into the river in the first place versus expending all of the tremendous resource to deal with them downstream. I think that we need to use data to inform the actions and the interventions that we're implementing. And more so now than ever, we need to strengthen the public and private partnerships, because I can imagine that the work of being able to make sense of these data, much of which is residing in an ambulatory care system and in a hospital system, those resources just don't exist in those places. All the resources right now are being deployed to providing care, but the kind of public-private partnerships that we could build would actually provide the support and resources needed right now so that we can make sense of that data and figure out where we need to be taking action. A few other things I wanted to bring attention to. I'm aware that there are other likely disparate populations. Again, we know that other racial ethnic minorities, we've heard about and seen the tremendous disparities that we've seen in the prison population, many of whom have zero opportunity to practice any kind of physical distancing, social distancing, PPE, and some of the basic things that we've been encouraging people to do, like hand washing, they don't even have the opportunity to do because in many jails and prisons, soap is not provided for prisoners. It's something that they have to pay for themselves. Similarly, other institutionalized population, we've talked, and I'll say another population is the elderly, and we know that about half of our COVID-19 deaths that we've seen in the US are coming exclusively out of nursing home and prisons. We've said nothing about other marginalized and disparate groups like the poor and sexual minority, the uninsured, as well as undocumented residents and people who have language barriers, including the undocumented and non-native English speakers or people with low English proficiency. Some policy initiatives that I think are needed are equity-driven access. That could include things like testing. I know there was a major rollout of money for FQHCs to do testing. And what I always say is if we don't build equity in, our natural drift is toward inequity. So there was no requirement that the populations being tested had to mirror the population in the communities being served. And so we've got some early data to show that there was a great difference in who was able to benefit from some of the testing that was rolled out. And Jack, I'll let him tell it himself. He is a great example about looking where the light is on. So only testing the people who have the ability to show up for testing, or only testing people that have symptoms, I don't think that's going to get us where we need to be. And I really think one of the most important things that we could do is require and build equity into the funding. People should not be able to receive state and federal dollars and not have some match of populations being served to the population in the community. And I think we need to be proactive versus reactive, or try to come in with post hoc interventions. We've got the data to sort of show what has happened. I think we need to start building that in. I'm gonna have to roll through these really fast. I think there's a lot of collateral damage of COVID-19 that we haven't considered from a public health perspective. I think we need to be taking those things on now. We've got a big problem with pre-existing health conditions and fear. People are waiting longer than normal and suffering at home from non-COVID related illness. That's resulting in excess morbidity and worse outcomes. I use the example of stroke. The longer people wait to go and get care, the worse outcomes they have, the less likely they are to survive. And we know that people are also dying at home. People are afraid to go to the hospital right now for fear of catching COVID. And I think we need to address that. We've also had big lapses in primary and preventive care. Child visits, as an example, are at an all-time low, as well as ordering of vaccines. And we can therefore assume administration of vaccines. That us up for potential unusual disease outbreaks following COVID-19, especially with the reopening. My heart is breaking. They've opened up Disney World. And I'm like, what does that mean, knowing that kids are not getting their standard immunizations right now? And here we are opening up major theme parks. And we did have a measles outbreak in 2019, mostly attributable to small, unimmunized communities. And we run the potential of emerging a less healthy nation following COVID-19. We know we also have some collateral damage and impacts around mental health. Our mental health care system was already lacking. We know people are under tremendous stress, and how we manage death and dying has changed. I've dealt with it myself. People are not able to be there with loved ones. They are not able to gather the way we typically gather when people die. And I think we need to address that. Same thing with behavioral health. And I know, because my training is as a substance abuse epidemiologist, many inpatient and intensive outpatient programs literally had to kick people out, and people were sent home with bottles and no other care. And we've seen in multiple cities, as a part of a system for surveillance that I'm a part, that we're seeing spikes in opioid overdose deaths. The bottom line, because I'm running out of time, I probably run out of time. In Michigan, what I'll say is that we do have some disparities in cases and deaths. You can see it's distributed geographically. We have done a pretty good job, and we are seeing, and this demonstrates a flattening of the curve in cases and a flattening of the curve in deaths. We've had a significant increase in testing on a daily basis. And the really good news is that we're seeing a decrease in the percent of positive among those tests. Again, the one caveat here is we're gonna find cases where we're testing. So I do think it's important that we continue to do the best strategy that we can, which is periodic, regular, frequent testing, especially among people who are asymptomatic. So in general, things are moving in the right direction. It's still too early to say we've made it, but many of us are cautiously optimistic. And I just underscore the need for us to continue to practice good public health. Last thing I want to say is, at the local level, We've got many counties in Michigan that are standing up local task forces. They are working from the ground up to address the gaps in testing and doing a really good job at starting to build the local efforts around contact tracing. And we're also really starting to address disparities and inequities broadly with these multi-stakeholder groups that represent multiple sectors of our society, because this issue of disparities and inequities is nothing that we can deal with just with testing or just from the bench or just with public health. It involves all of the sectors of our society. This last thing, this is a great little 5-minute video if you want to sort of share with others around how we could be thinking about upstream, downstream, and how to stop people from going into the river. And it's called The Cliff of Good Health. And it's a really good animated talk that's just 5 minutes by my colleague, Dr. Kamara Jones. And I'm going to stop there.
Thank you very much, Dr. Holden. Great information and a great perspective on the public health side of things as we see them now and for moving forward. And I greatly appreciate that. And I appreciated the information from you, Dr. Lipton, on testing, the processes, the supply and demand issues, as well as the issue of testing for antibodies. I've had no questions come up on the Q&A, but I do want to see, before we move on to Gwen Sheely, if there are indeed any questions of Dr. Holden and or Dr. Lipton before we move on here. So if any of the participants indeed have a question, you can type it in the box or you can raise your hand and we'll take your question. Okay. Well, continue to give that some thought then, and we will move on now to, oh, wait, we do have a question. Oh, the website. Yes, Dr. Holden, the slide with the YouTube video. Could you put that up one more time? And if Dr. Holden's not able to do that, we will get that to everyone as well.
I am, and actually what I can do, I'm sorry, I'm gonna put it in the chat.
Okay.
If that is helpful so that everybody can see it. And I will also answer the question in the Q&A, and I put the link. I put the link to that video in the Q&A.
Super, good deal.
Yeah.
Thank you very much.
Okay.
Okay, then with that, let's see here. Oh, here we go. Maybe for Dr. Lipton. Should people even bother getting tested for antibodies at this point in time?
It's a great question. It depends on if you thought that you were sick or not. And I think that once it's available en masse, I think it's worthwhile to test whether you think you were sick or not, because some of these cases are asymptomatic, and so you may have been exposed to it. A certain percentage of people don't have that. If you can get access to the test and you want to, I think that as long as you're getting it through a reputable health provider and not buying a use-at-home test right now, I think you'd be safe. There are a few out there, and you can cross-check this on the FDA website. So if you want to find out from your healthcare provider which test they're using, which antibody test they would use on you, and you can find out the manufacturer, you can go on that website and find out if that is an approved test. And if it is, and you know that for a fact, and you can feel confident that it is going to work, because most of the approved ones, as far as I know, have really, really good accuracy.
Super.
Yep.
Thank you very much. And again, continue to please post your questions, and we'll get to them at the end of the webinar. And now I'd like to introduce Gwen Sheely from MSU Extension. Gwen, the floor is yours.
All right. Well, thank you for having me here today. Like Arnold said, my name is Gwen Sheely. I'm an educational technology specialist within MSU Extension. So my role is to help our staff integrate technology into their programming, and I'm going to be sharing with you some examples here today throughout my presentation. So integrating technology into our programs is definitely something that we're working on previous to the last few months. We talk about this a lot because if you're familiar with Extension, you'll know that our staff were located all throughout the state, and our role is to help bring science-based information from the universities out into our local communities. And we do this many different ways. Obviously, we do this in person, but we also look at the needs of our target audience and look at the best ways to reach them. And sometimes it may be through an online article. Sometimes it's through an online course or a webinar or through social media. And so this is something that we've really ingrained into the development of our programs over the years, and which really I kind of put us into a pretty good position when all this happened. And we really needed to focus even more in terms of putting content online. So the first area I'm going to talk about today are online courses. And I'm also going to be talking about giving you some examples of webinars too. And I'm going to go through these examples kind of quickly just to share with you a lot in terms of the breadth of the offerings that we have. But hopefully throughout my short talk here today, maybe you'll find something that you're interested in yourself, or for yourself, or obviously for constituents within your areas as well. So we're going to go on a little bit of a virtual tour here. And I do want to mention one thing with our online courses. These are different than what you might find, let's say, in a credit course at MSU. These are non-credit courses. Sometimes people may get continuing credit through an organization or association, but they're all varied. Some of the online courses may take someone an hour or 3 hours to go through, and some may take 10 hours or more. Some of these are self-paced. Some of them are more cohort-based, meaning that participants will go through the course together. There's online discussions and things like that. So I'll be talking about that as I go through here today. But before we get too far, I wanted to just give you a little bit of data about our online courses that we offer. And so we have a little over 70 online courses, and these may be online. They also may be blended. When we can have face-to-face interaction, it may match along with some online learning as well. And, in various different areas, whether it be agriculture, health and nutrition, looking into our communities and looking into environmental concerns and things like that, or topic areas, as well as youth programs as well. We always have a lot of online courses that are in development as well. And these are things that do take time to develop, to do them well, and to make sure that we're offering quality content for the people that we serve in our counties. Now, over the past few years, the number of participants in our online courses has definitely grown. And as I look at numbers so far in 2020, I definitely think that this year is going to be even much higher as well. So we're continuing in that direction. So now I'm going to start going through some examples that I'm going to share with you from some of our programs. And I'm going to start out with talking about a lot of things that we're doing in the area of farm stress. And I'm sure many of you are familiar with many of the stressors that our producers have faced here in Michigan over the last couple of years. Of course, last year we had a lot of delayed planting with our unusually wet weather that we had. Really caused a lot of stress to our producers, and that's continuing now. We're not out of the woods yet, and a lot of stress within this industry and within this area. Now, MSU Extension had been doing a lot of work in the area of farm stress for a long time, and over the last couple of years, we partnered with USDA, and specifically with the Farm Service Agency, to put together training for Farm Service Agency staff, those who give out loans to producers. And we put together a blended approach. It was a self-paced 3-module online course, which focused on communicating with farmers under stress, introducing them to identify stress in themselves and others, as well as suicide awareness. Now, participants in this program, they went through the self-paced course, and after that, we had several online meetings that they signed up for. We had 500 people in our initial pilot, and the online meetings were smaller. They consisted of 20 to 25 people, and were facilitated by someone who had expertise in the area of mental health. And what they did was they really reflected back on the self-paced course in terms of what they learned and thinking about how they could apply it in their own circumstances. Now, all of this was also followed up a few months later. Back in the fall of 2019, we had a face-to-face training for these individuals, which completely focused on scenarios. So giving them scenarios, they were in small groups once again, and they talked through these scenarios, walked through them with an expert who helped them with that. And that program, I should mention too, the USDA one, right now we're editing some of the content that we did with that initial 500, and they're planning to roll that out to all of their Farm Service Agency staff, which would be about 10,000 individuals. Now we're doing some additional things in the area of farm stress too. On June 15th, we're going to be launching a free MOOC, massive open online course in the area of farm stress. This is a partnership that we've been working with on this program with the National Farmers Union, Farm Credit Council, as well as American Farm Bureau. And this is a training that will be open and available for anyone who works with farmers and producers. And of course, anyone can enroll, farmers could enroll as well too. And also doing, we also want to mention we have a small research study that we're also doing to see if text message reminders can be a good way to reach farmers directly with information on how to handle stress. So just kind of an example of a few things we're working on within this area. All right, moving on to some other programs. Greenhouse floriculture. This is a long-standing program that we've had within MSU Extension. This content was initially offered in person, and then about 10 years ago, they went to go move it online, and we've been continuing to offer it and upgrade it and make changes to it since then. This is more of a cohort-based program, so it's offered twice a year and is 6 weeks long. And something kind of different about this course is that it's also offered in Spanish as well. So we have, there's 4 courses, 3 of them are in English and 3 of them are offered in Spanish. Another course that, this one's kind of brand new. So this one we just launched a month ago. It's called Smart Gardening with Vegetables 101. And our experts here, Sarah Rudio and Rebecca Kranz, they had offered this content in a webinar format. And then we worked on putting it into taking those recordings, chunking them up into smaller segments, and adding some activities and things to that, and developing an online course. Well, this course has been wildly popular. In the last month, I checked this morning, we were at 901 participants that have signed up just in the last month. So kind of a neat program to talk about. This is another one that's kind of unique. So a logger training. So Jesse Randall he works at the MSU Forest Biomass Innovation Center up in the UP. When everything started happening over the last few months, he contacted me and said, hey, we've got a problem up here. They had a whole bunch of loggers up in the UP that needed to get certification before they could continue throughout the year. And he said, you know, we're not going to be able to have this training in person. What can we do? And so we worked together to quickly put some of the training materials online to make a training refresher course certification. So participants can go into this course. They have to go through a certain number of hours of training and then can request some certification credits. Another course that we and this is a long-standing course that we've had within MSU Extension. I first worked on this course back in 2007, so it's been here a long time. But this is a citizen planner course, and this is one that focuses on people out in the communities that may want to, maybe they're a planning commissioner or something like that, and they want to learn more about land use. A couple years ago, the individual that was in charge of this course said he was about ready to retire, and he said he wanted to revamp it, do something different. So he really focused on something called digital storytelling, because the course previously was a lot of text. It was a lot of text on the screen, not a lot of interactivity or anything like that, and he really transformed it. So now there are 24 episodes, and there's an expert from MSU Extension that will come up in a video kind of to introduce the story. It goes through the story. In this example, this is Neil, and he's going to attend his first commissioner's meeting, and goes through the steps. The expert comes in after the story, talks a little bit about what participants just learned about, and then it goes through a series of interactive activities. So this has been a very popular course that we have offered. Another fun one that we all have offered for quite a few years is called Introduction to Lakes. So this course is geared toward anyone who is interested in lakes, and obviously here in Michigan we have a lot of people that live near lakes or on a lake, and this is a cohort-based course, meaning that participants register by a specific date and they go through the course together over 6 weeks. It has a course facilitator and several different experts and faculty members who have an extension appointment that help with it. There's discussion forums in it and Q&A sessions and things like that. And this screenshot right here, this is one of the highly rated videos in the course. This is Sebastian the Goose, and he talks to the participants about natural shorelines. Another course that has been really popular, a couple years ago, we developed something called the Pollinator Champions online course, and people love to learn about pollinators. It's a really popular topic. The individual in the screenshot here, that's Dr. Megan Milbrath, and she is a pollinator expert here on campus, and she was continuously getting requests from people to go out into the communities and to give presentations on pollinators, and she couldn't keep up with it. So we came up with this train the trainer approach where we created a self-paced online course that's open to anyone. Anyone can go through it, and it's highly interactive. And this screenshot here in the front, this is an activity where, based on inputs, the blueberry bush is either going to flourish and show a lot of blueberries, or if you select the wrong response, it may not look so good. And once participants are done with this course, what they can do is they can pay for a secondary course where they get their certificate. They get training materials that they can use within the community, and they also get added to a database that Dr. Milbrath uses when people make a request for someone to have a presentation somewhere. So that's what we've kind of created through the Pollinator Champions course. Moving into some health and nutrition type courses, a brand new one that just launched about a week ago is My Way to Wellness. This one focuses on healthy living, focusing a lot on things such as your plate, the foods that you choose, recipes, also labels and things like that. So thinking about healthy eating. Food safety for food service workers. This is a self-paced online course that is intended for frontline food service workers. It focuses on things such as safe sources and temperatures, and cleaning and sanitation, and health and hygiene. Another example of kind of health and nutrition related type course is cottage food law. If you're familiar with the cottage food law, individuals that sell things such as, for example, at a farmer's market, it's kind of where we were at when we shot this video here. They have to meet certain stipulations and meet certain regulations before selling their foods. And so this course goes over all of the things that they need to meet in terms of the food safety aspect. And then just recently this spring, we also added some information from folks at our product center at Michigan State to include information on creating a marketing plan, on your financials, and creating a business plan and things like that. So kind of coupling that with the food safety to give people more information that they would need to sell foods. Going into kind of thinking about different areas focusing on youth, here's a great course, Building Early Emotional Skills, otherwise known as our BEES online course. And in this course, we have two separate versions of it. So there's one version for parents and one version for child care worker professionals. And obviously it focuses on how to interact with children and things like that, and building those emotional skills. And the one for childhood professionals, that course, they can also get continuing credits for it as well. Now, the last thing I want to mention here when talking about online courses, and this isn't a formal course that we did, but it's a great story, and it's a great program that we did, and I love telling this story. Sometimes what we can think of are learners as creators of content. So when we're teaching individuals, how can they also use that information as a learner to create new content to share with others? Now, in this program, there are some of our staff who were creating some training. They wanted to create emergency response training for migrant workers. However, they knew that they would not be able to get those individuals to the training in the summertime because they were busy, they were working in the fields. And so they came up with the idea, well, let's invite their kids, let's invite the youth to join this training and teach them and have them go back and teach their family members and things like that. So they went through the training and they were trained in terms of CPR. They were trained in areas such as first aid and things like that. And they went through some fun scenarios. Here was a scenario where we were pretending that there was a train derailment. And they had to go through and take the staff and they had to identify them and group them based on their injuries and things like that. And they were obviously experts that were teaching this that gave them feedback. And we went through things such as what would you do in terms of a fire and things like that. And at the end, I was there and I helped videotape some of the segments and take some pictures and things like that. We had video footage from the youth that were at this training, and they demonstrated what they learned in terms of CPR and first aid and things like this. And they did this both in English, and then some of them did it in Spanish as well for the videos. And then the youth took all this content and brought it back to their families and their local communities. So it was a really, really neat program. All right, so now let's focus in. I'm going to talk a little bit about webinars. Obviously, we're in a Zoom webinar today, and I'm sure most of us have been doing more Zooming than we ever thought possible in our lives. And this is something that MSU Extension, I mean, our staff, as I mentioned earlier, are all across the state, so we're pretty familiar with using Zoom, but definitely upping our skills to reach more audiences. So I'm going to talk through some examples here in this realm of things as well. So the first one I'm going to mention is our virtual field crop breakfast series. And this is an early morning series with 15-minute topics on a farming topic and a 15-minute segment on weather. And we've got Jeff Andreessen, who's a meteorologist from MSU, that does that segment. Food safety, doing a lot in this area. We have a food safety Q&As. We've been doing a lot also with food preservation. Just talked to some folks yesterday. They opened up a week ago a food preservation webinar series a week ago, and they already have had 1,000 people register. So doing some good things here. Cabin fever conversations. This has been a really fun series that has been developed for informal conversations about things relating to gardens, things relating to insects or houseplants. And they've had over a couple thousand people register. We broadcast this on Facebook Live as well, and just have gotten a really good response from this one as well. We're doing things in the area of social and emotional health, mindfulness, alternatives to anger, and things like that. Another one you may have heard of in the news, this one got a lot of broadcasting in the news media and things like that. It was called Adulting 101 for 11th and 12th graders. And this focused on things like creating a budget, your credit, how to go through the process of renting for the first time, cooking 101, and also house cleaning. So the basic things that someone might need as they move out of the house. And this one also, we had well over 1,000 people register. Just quickly, I know I'm ending my time here a little bit, but I'm going to talk a little bit about social media because it's a good place to find out about some of these programs. So our MSU Extension Facebook page, Instagram, and Twitter, great place to go to find out about some of these programs we offer. My Health Matters is a great one to go through to for information about health, so eating healthy and things like that. My Stronger Family is a great one for resources for parents, whether it's activities and discipline, things like that. Gardening in Michigan is another great one for those interested in that area. We also have an Ask an Expert online form that's been around a long time. Last year we had about 6,500 questions that came through here. And basically when those questions come through, whether it's gardening, that's where we get the most questions on, but it could be agriculture or health and nutrition or anything, and we connect those questions to an expert. So far, even just in the first half of May, we've had almost 700 questions just this month. You may also have heard about how many of our county fairs are possibly canceling their events. Just wanted to mention that we are working on a virtual showcase and auction to be a resource for those counties if they choose to use this, to have some virtual exhibitions, shows, and auctions and things like that. And lastly, I just want to mention that if you're interested in any of these topic areas, the place to go is got the website up at the top of the screen here, but it's our remote learning website. On that website, you can filter down to different areas to find more information on these programs or do a search on our website. And then also I'll note down at the bottom of the screen, there's a virtual events. That's a great place to go to find where some of these webinars and things are happening. So with that, here's my contact information, and I hope you've enjoyed this brief kind of tour of some of the programs that we offer.
Thank you, Gwen. Great information, and great to see how Extension has, as usual, adapted to the times that we're in and providing content for residents all across the state of Michigan. I think it's been quite an advantage to have the programming that you do be available, and now virtually as well. So again, open, now is the time for any questions. No questions in the chat box, and I don't see as of now any participants with a raised hand. But you've got an opportunity to chat with folks, Dr. Lipton and Dr. Holden in particular, experts in the medical field and public health, spending a lot of their time working with solutions to the coronavirus, both on a public health community level and in the lab. And of course, Gwen Sheely from Extension. And again, just a reminder that this session has been recorded and will be made available as well. And the PowerPoints that you've seen will also be made available. And we'll let you all know when those get posted. Any last words from our panelists? Again, want to thank you all for taking time. I know how busy everyone is. Thank you to our participants for taking time. Thanks to Cindy Kyle of the IPSR staff for helping pull this together. And with that, we will sign off and see you next time when IPSR hosts our next legislative staff training. Thank you all.
Thank you.
Thanks.